I'm glad you've been here. It's been a pleasure having you with us.
Pleasure having you guys.
Yeah, okay. So I will email you from Brightspace or from my SUNY Duchess email. And if that doesn't work, grab it from one of these folks. But try and get that fixed because other folks may send stuff to you.
Yeah.
And in future semesters, and you're going to want to have that.
Yeah.
Question.
That.
Have you gotten his other email?
I send like probably twice a week. I send emails out.
What?
What do you do?
At least I
At
know.
least sent, yeah, you sent.
Dana just sent it to me, so we're good. All right, thank you.
Got a little nervous there.
Yeah, I was also wondering for a second. 2 a week, wait.
You asked something.
All right, so tonight we'll do this review. I do have the autopsy presentation that we developed a couple years ago, and we'll go over that as well. I just have not heard back from the ME, and so I'll just go through that stuff with you. I was going through it today, and I thought, my God, the guy who wrote that was a student of mine and has worked and retired. And I'm like, what am I, I feel old. But then went on a cardiac arrest today with Jen Swenson / Crandall, and it was like,
And I usually ride with her on Wednesdays.
oh really?
Yep.
Oh, that'd been fun.
I used to throw her like 20 feet there.
So I still enjoy doing it, so that's great. So we'll do that tonight, answer any other questions you may have. Please make sure you've gone through Boardable and looked at everything that's there and it all seems copacetic to you. There are 2 news articles I have yet to grade and your paper that I have yet to grade, right? I haven't looked at that yet to give you the opportunity to update it however you saw fit until this week. And Annie, you said that you couldn't upload a new one, so you had to email it to me. If you've redone it and couldn't upload a new one, just email it to me by the end of tonight, tomorrow. I'll probably get to them this weekend, is what I'll do. But I wanted to give you all the opportunity to update your papers because you hadn't gotten that feedback from me on your abstracts, and I think that was fair. Okay, next week I'm at State Council Monday, Tuesday, Wednesday, and it's in Saratoga Springs, so I'll be back down as soon as possible. I've worked out with Bernadette someone to start the exam here at 6. I will get here as soon as feasibly possible afterwards, and I will grade it that night just like I did with the midterms, so that you at least have an idea of where you stand with that. I think everything else should be in. I think that covers everything that we've talked about. The exam, the final exam, is from the midterm on. So not on the midterm was inflammation, infection, right? I don't think that was in the midterm because we had just talked about that the week before. I think that was where I put on there. So it'll be inflammation, infection, onward are the things that are on the final exam. It's set up like all the other ones, matching, short answer, essay, that kind of stuff. Go through your quizzes, go through the slides, stuff in the book, blah, 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 and you should be in pretty good stead with things. I think you all have all of your quizzes and group stuff back, so everybody should have everything that way, right? Let's see, what else? I think that's it. Have we done everything that we said that we were going to do for class?
I have a question. What did you say about the last 2 article reviews? You didn't grade them yet?
I didn't grade them yet. I got to do them still.
Which?
Those were like 6 and 7 or 7 and 8 or
Okay,
something like that.
Because like the last one or two you said we weren't.
You didn't have to do.
Okay. And I panicked for a second. I thought maybe I misheard you.
No, everybody but you. Since you asked. So that's where we are. All right. Have I missed anything? Do I owe you anything? Other than those things I talked about. Okay, what would you do differently with this class if we were to do it again? And I'm not supposing that we're going to do this again.
Maybe a little bit farther apart than 1 week between the abstract and the final paper due. Add like 2 weeks instead of the 1,
Okay?
so that you have more time to like take what you put for the abstract and then like put it into.
Okay, yeah, that's fair. I can do that. Good idea.
I'm almost.
Okay. Cool. Anything else?
I bring this dog to class more often.
Well, I don't want to have to fail Annie every time, so.
I think
Just
it
this
did-
once, it's fine.
I think it did wind up being better to wean off of the news articles after we started getting heavy into the paper. Because I wound up being able to spend more time on the paper after we stopped doing the articles.
Okay. All right, so that was helpful to pare those down a bit. Okay, good. Were the articles helpful? What did I want you to get out of that?
Critical thinking.
Okay, so when you say critical thinking, how? Describe that for me. What does that mean?
Want us to look at different perspectives and think even if we didn't agree with them.
Have you?
Yes,
Honestly.
I think so. Or I've tried, even if I saw something and I agreed with what it was right, what was being written, I went out of my way to try to argue on the opposite point, like in my own head.
And so it's beyond just what's written that you look at. It's what people tell you. It's all kinds of things that you should absorb and appreciate the viewpoint and perspective from where it comes, and also realize there may be other valid perspectives that are valid perspectives, and just consider that. I think that's a really important thing to do in figuring things out. And it's going to be really important for you all to do moving forward, very much so, in this field. Okay, so good. Yeah, critical thinking, I appreciate that. You did it. I mean, you brought it up.
Allie, come here. Your sister over here. Sorry, she loves gummy bears.
You kind of brought it on
I
yourself.
can't have them in
just
my
saying.
house.
Okay. All right. Good. Any other thoughts about the course? Any other things you'd like to see, do, not do?
I
Okay.
like the word searches,
Okay.
not the crosswords. I'm not very good at them.
Okay.
Yeah, I like the crossword.
All right. Good. I'm glad those are helpful for y'all to do that kind of stuff.
And the coloring sheets.
Yeah, coloring sheets I found really effective when I was going to school. It was really helpful with the A&P and the patho for me. So that's good. Okay. All right. Good. Okay. If there's stuff and you think about it, great. Let me know. That's cool. And for the rest of the program, please know that I can be a good resource for you. I want to be helpful in some way, shape, or form. If it's whatever it is, just please let me know. You can reach me. You have all my contact information, obviously, so you can do that as well. And I'll be around a little bit here and there through the other programs to help out when and how and where I can. So I'll be around. Okay, cool. So let's go over the review section of this. While the stuff that's on these first couple of pages is not on your exam, please take a look at it. Please review it. You will see these things again. I don't want you to be like, done with that. Don't gotta think about that again. And we're out of here, right? So please continue, just at least look through those. If you have any extra credit stuff, I for sure need it by next week. So if you don't have it with you tonight, I need it by next week. Okay? Okay, so I'm going to start with inflammation infection, and I'm going to go through this, and I kind of don't want you to read this as we're going through it, because I want to see, and I want you to see what your recall is on the thing, on the topic, so that you have an idea of what you might need to study or not study. Like, I know that, I don't know that. If you just read it, then it's right in front of you, and I could just give this to you to read, and you don't need to have me standing in front of you reading to you. I mean, that's lovely, but I'm sure there's other things you have in your mind of things to do, right? Than me doing that. So, so consider that. All right. So, list for me, this is inflammation infection. List for me some physical barriers. Out loud, Jed. Mucous membrane. Skin. Those things.
The acidity on the skin, I guess.
Acidity of the skin through oil, sweat, sebaceous things. What else? Another huge physical surface barrier. Bacteria. Yes, absolutely. All kinds of other bacteria that are there. Okay, good. So that's there as well. This is a quick and stereotypic response of isolating, destroying, and cleaning up an invader. Inflammation. This is a slow but specific response of antigen recognition, antibody production, foreign substance neutralization. Immune response. These cells release histamines when injured. Mast cells, what's another word for them? Histocytes. Okay? Histamine causes local blood vessels to dilate, bringing additional blood to the area. That is called dilation of vessels to bring additional blood is called hyperemia. Okay? We good? What are the first white blood cells generally to get to an area? Leukocytes are sort of everything, right? And you're going to have to correct this in here, I think. But what's the first ones? Starts with a G. Granulocytes, right? And what are they? Neutrophils, basophils, eosinophils. Okay? Finally, after that comes monocytes in a few days, lymphocytes, week or so after than that. Okay? This is a clear serum-like substance that contains small amounts of protein. What kind of exudate am I talking about? Serous exudate, right? Clear serum-like, small amounts of protein. That's serous exudate. This fluid has large amounts of fibrinogen, usually found in strep throat, bacterial pneumonia, that kind of thing. Fibrinous. Large amounts of fibrinogen, fibrinous. Okay? This is loaded with dead and dying neutrophils, tissue debris, and pyogenic forming bacteria.
That's
Thank you. Very good. We're there. Okay, that's purulent. Tissue healing is based on what? Predominantly. There's a large incision, jagged wound, or something like that, whatever. What's tissue healing dependent on in that situation?
The edge of the wound is straight or if
and that they wound edges are
Clean, or, not clean, but like,
line up nicely. That means another word for that. Approximated. The wound edges are approximated, and that the wound is clean, and there's no other stuff going on in there, and there's a good blood supply to the area, and you get them close enough to be able to cleanly dress and close and have good capillary function in the area, good bleeding, all those kinds of things, to have all the rest of the stuff happen. Okay. And so that's wound edge approximation. What are some complications of wound healing? So all those things I just said are good things to have in the wound healing process, right? You need a good blood supply, wound edges approximated, granular tissue forming, filling in with other kinds of tissue and et cetera, scar formation, all that jazz, right? So what are some complications? Yes? Right? Not a good blood supply. Infection, absolutely.
Or scar formation.
Yes, or scar formation. If the scar doesn't stay, right? Because it's in an area like an elbow or a joint or whatever, where it keeps moving and it gets ripped off, or we just like, let me pick this off the scab because we don't need that anymore. Adhesions and keloid scar formation because of excess collagen, right? These are all a variety of reasons for complications of wound healing. All right, so some criteria for infection. Give me some criteria for infection. Why can infection happen? There's got to be some variety of things related to this happening.
Virulence?
Yes, of the individual and the pathogen, right? Okay, good. Yeah, absolutely. All right, and what's the most predominant route of entry? Yes, respiratory system, inhalation. Very good. What are the other routes? Ingestion, injection, absorption. Okay, good. Very good. Okay, what are some other things? So route of entry, resistance, virulence,
The amount of the disease.
the amount of the pathogen, right, that comes in. If it's a tiny, small amount, think paper cut. Versus a huge amount for some kind of reason, right? Okay, so the amount coming in, absolutely. And the ability to overcome the defenses, which is part of virulence of the pathogen to the individual. All right, good. Any other thoughts about inflammation, infection? Okay. All right. On to some self-defense mechanisms. This occurs as a result of active prior exposure to an infectious agent or its antigens, or a passive transfer of antibody or immune lymphoid cells. What is that called? Acquired immunity. Very good. This is acquired, either active or passive immunity, produced by deliberate exposure to an antigen, such as in a vaccination. Artificial immunity, very good. Okay, vaccinations, artificial immunity. You're not actually exposed to the pathogen. You're exposed to a version or some piece of the antigen of the pathogen, and that creates a systemic response of the immune system. Okay. This is an acquired immunity in which the role of T lymphocytes is predominant. Cell-mediated immunity, very good. Okay. This is the resistance of a group to attack by disease to which a large proportion of the members are immune. Herd immunity. This is an acquired immunity in which the role of circulating antibodies is predominant. Humoral, yes, humoral immunity. Very good. Okay. This isn't going to be on there. This is humoral immunity passively transferred across the placenta from mother to fetus.
Maternal immunity?
Maternal immunity. These are foreign substances or cell markers. Antigens. Okay? Foreign substances, they're cell markers. The cell marker helps the body to determine whether it's foreign or not foreign. And so it is a cell marker period. The body decides whether it's foreign or not foreign. These are proteins which attach to antigens, destroying them. Immunogens. Okay, immunogens. This is the major immunoglobulin in the blood. It is able to enter tissue spaces. IgG. This is almost exclusively found in the membrane of B cells, where it somehow regulates the cell's activation. IgD, very good. This is normally present in only trace amounts, but it's responsible for symptoms of allergies, especially this season. IgE, okay. This guards the entrance to the body, and it concentrates in body fluids, tears, saliva secretions, respiratory and GI tracts. This is IgA, very good. And this is a star-shaped cluster, remains in the bloodstream, usually where it's good at killing bacteria. M, IgM, very good. These cells produce antibodies that form complexes with target antigens. These are B cells, okay? And again, don't just read off the sheet, like try and do this without reading there first, okay? These cause vasodilation, increased permeability of the vasculature, and pain. Vasodilation, increased permeability, and pain. Kinins, okay? These cause inflammation, vasodilation, increased permeability, and pain. Prostaglandins. Okay, so we're going to add inflammation to that previous one. It goes from kinase to prostaglandins that do that as well. These cause contraction of bronchial smooth muscle and development of inflammation. What did you say? Okay. No. Leukotrienes. And these are produced by macrophages, activated by lymphocytes, stimulate and activate proliferation of B and T cells. These are cytokines. Remember that there's something that's that's exuded by a cell and is a messenger. It's usually a cytokine in some way, shape, or form. Okay? Okay, good. Fluid electrolyte acid-base balance. So, body fluid is in one of three places. The interstitial space, which is a third space. Intravascular and intracellular. Now on that slide, I did look at that and saw that plasma was a piece of that, right? Talking about where that fluid was in the vasculature. And so yes, that vascular space, that's where it is. It's considered plasma in that space as a fluid portion of the component that's intravascular. So I give you all credit on that quiz for those of you that answer plasma and not intravascular. Just recognize that, and I should probably change that slide because I'm talking about the kind of fluid that's there versus where the fluid is, but intravascular, interstitial, and intracellular, okay, is those things. This is a substance that's dissolved into a solution, solute, and the solution is called a
Solvent.
solvent. This is the capability of a substance to diffuse through a membrane, right? And when it's selective, semi-permeable. These promote neuromuscular irritability, maintain body fluid osmolarity. Electrolytes. And what are the four main electrolytes? Sodium, potassium, calcium, magnesium. Very good. This is the movement across a permeable membrane.
Osmosis?
Diffusion, right?
Oh.
So this is good, right? This is a good question. The movement of a solute across a permeable membrane or semi-permeable membrane is diffusion. The movement of a solvent through a semi-permeable membrane is osmosis. Very good. Okay. The force created by two solutions of different concentrations separated by a semi-permeable membrane creates osmotic pressure. This occurs when a cell membrane moves molecules or ions against a gradient from an area of lower concentration to an area of higher concentration of those molecules. Active transport. It requires active transport to do it. It's not passive. Passive will equalize through either diffusion or osmosis. The force a fluid exerts outward against its container is called hydrostatic pressure. The movement of fluid through a semi-permeable membrane from high to low hydrostatic pressure is called filtration. Very good. Yep. All right, good. This occurs when there's increased interstitial and intravascular fluid. We're in the fluid electrolyte and acid-base disturbance. When there's, well, you wouldn't have third spacing necessarily if the fluid is in the intravascular space. It would be more so in the interstitial space. This is when you've got more fluid in the interstitial and intravascular space. Fluid volume excess, right? Or fluid overload, or edema in some way, shape, or form, right? This occurs when there's vascular, interstitial, or intracellular dehydration. Fluid volume deficit. Okay, you don't have the fluid, it's not in those spaces, you can't move it back and forth and around. That's fluid volume deficit. What can cause fluid volume excess? Poor functioning of the heart, to not move it around. Poor kidney function, overhydration, electrolyte imbalance, right? All these things can cause fluid volume excess. What about fluid volume deficit? Yeah. Excessive urination, poor fluid volume intake. What'd you say? Vomiting, diarrhea. It would be a little different if you hemorrhaged to a point where it was on the edge and you didn't have fluid intake and the hemorrhaging stopped so it wasn't life-threatening and you were still able to recover, then you could potentially, have some kind of fluid volume deficit or dehydration in some way, shape, or form. Right. Okay? Severe burns, sickness, illness can cause dehydration, especially when you don't have fluid intake. Excessive sweating, exercise, those kinds of things when you don't have fluid volume intake will all be causes of that. Okay. What part of the buffer system readjusts pH in seconds? In seconds. So really it's the carbonic acid buffer system, part of the extracellular buffer system, right? When you talk about the respiratory component of that system, it can readjust pH in minutes, typically, right? And then what is the other side of that? The renal side, and that takes how long? Hours to days, absolutely, right. Okay? What's the usual pH? Sounds about right. 7.35 to 7.45. What's the typical PaO2, partial pressure of oxygen?
80.
80 to 100. PaCO2? Bicarb? Base excess? Plus or minus 2, right? Okay. What are all of our carbonic acid excess? So we have carbonic acid excess, right? What is that? Respiratory acidosis and carbonic acid deficit. Okay. And what are the other two?
Metabolic acidosis, metabolic alkalosis,
Right, and what's the other terms for those?
bicarbonate.
Bicarbonate deficit and bicarbonate excess. Okay, very good. What are most people in? Respiratory acidosis, right? Most of the time. That's what folks are in. Okay. All right, good. And so if we have a pH of 7.3 and a CO2 of 55, what is that? Respiratory acidosis. Okay. pH of 5 and a CO2, sorry, pH of 7.5 and and a CO2 of 30.
Metabolic acidosis, respiratory alkalosis. Did I just switch them? I just
So
switched them in my
pH,
brain.
so pH is what? 7 point.
Alkalosis.
I said metabolic alkalosis, am I right?
So it's an alkalosis, and what's the CO2? Which is low, so it's respiratory alkalosis. Opposite directions, okay? That's all right. All right, so review those particular things and review that quiz that has all those scenarios on there. That's a good thing to take a look at, okay? All right, what does the oxyhemoglobin dissociation curve represent?
Factors that
Mathematical equivalent.
factors that influence the affinity of oxygen hemoglobin. How it wants to either hold on to it or release it.
Against the partial pressure of oxygen that's available, right? So it's the affinity of oxygen to hemoglobin based on the partial pressure of oxygen available. Okay? So you have to have those two things that are in there. What can cause the curve to shift to the right?
Anything that goes up except pH.
And how would you correlate pH going up? Well, so pH would go down, right? But what goes up to make pH go down? Hydrogen ion concentration. So if you think of everything going up and that being hydrogen ion concentration makes it go to the right, you would be correct because the pH would drop with a high hydrogen ion concentration, right? So what are those things? We've got pH, temperature, DPC, DPG, sorry, yeah, DPG. Yeah, it's not Renan. Yeah, this is just stuff we learned. And then some just metabolic activity of the body, right? Okay. What makes it shift to the left? decreases of those things, right? So if you have a decrease of hydrogen ion concentration, that creates a alkalosis, right? pH that goes up. And so decreased temperature, decreased DPC, all those kinds of things, right? So what happens to oxygen hemoglobin as the curve shifts to the left? Affinity for oxygen increases on the hemoglobin, right? Which means the tissues aren't getting it as readily. And what happens when the curve shifts to the right? It's the opposite. There's a decreased affinity of oxygen to hemoglobin. And so it gets released to the tissues as long as you provide the oxygen. If you don't provide the oxygen, then the tissues don't get it, period. Okay? Does it all make sense? Okay. All right, good. You all learned a whole mess of stuff with that, right? All right, what's your question, Mackenzie?
Wait, which, so, when does it get oxygen compared to the
This is normal.
Can you use a different color? Sorry, I can't.
Yeah, we can't see that.
Really?
No.
It's-
Use the black one. The black one's brand new.
Okay, so what's happening here? We've got
Decrease in, oh, we have an increase.
right? Curve that shifts to the right.
Oh.
Yes? Okay. And on the other side, when the curve shifts to the left, we have a
Is the DPG actually increasing to the shift to the left because it fights for the receptors so that, never mind, it makes sense going to the right because it releases the oxygen, so it's fighting for the receptors so it doesn't hold on to oxygen, never mind.
Okay, and so in this case, we have movement to the tissue. In this case, we have movement to the hemoglobin. And we like to be right in here. Okay, does that make sense,
So
Mackenzie?
when the shift is to the right, the movement of oxygen is to the tissue?
Yes.
Okay.
And this is more acidic, right? And this is more basic. Or alkalinic. Okay, good. Anything else with this piece of it? Okay, let's look at hypoperfusion. What percentage of oxygen is utilized in capillaries by tissues for aerobic metabolism?
25?
25%, generally speaking. And how much can that go up to during tissue demand or when the body's stressed? 50 to 60%. Okay? What process gives less energy yield, produces lactate and toxins? Anaerobic respiration. What is cleared more quickly from tissues, lactic acid or carbon dioxide? Carbon dioxide absolutely gets cleared a lot faster from tissues than lactic acid does. Tell me what the consequence of stroke volume is. Stroke volume is a consequence of preload Afterload and contractility. And what is preload?
How much is it? Right?
It's left ventricule.
Left ventricular end diastolic volume. Very good. Okay. And that's the amount that's available to the heart prior to the contraction. That's the final filling point before the heart contracts. Okay, preload. What is afterload? Come on now.
Like pressure on the blood vessels after during systole?
Right, so it's the pressure against which the heart has to overcome during the contraction to allow for blood flow, right? And so that is that resting pressure. That's afterload, okay? And we can call that, we've talked about this, right, Dana, that's the ventricular wall tension, that's that afterload. Okay, and contractility is what? Yes, that is contractility. Very good. Okay, we all got that. Just draw that picture on the test and you'll be fine.
If I was this, like,
Yeah,
but
but
I.
Yeah. Question 54? All right, are we good?
Yeah.
Okay.
They'll look at you and be like, good, no.
Yes. Yeah, so that is the muscle contraction, the ability of the heart to contract. And if the heart does not have that ability to contract, then regardless of however much preload is there, and even how low afterload may be, you may not actually get blood flow because of the loss of ability to contract for a number of reasons, right? And that could be because of trauma, defect, pressure on the myocardium from either the pericardium or pneumothoraces, or things like that, all that kind of stuff. MIs, blah, 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 all those things. Okay, what is the equation for cardiac output? Cardiac output is, yes, stroke volume times heart rate. Good. What's the earliest and most effective means of controlling cardiac output? Heart rate, increased or decreased? Right, and so, oh,
So up to a certain point, which is, I think the magic number is 150.
150, right. So now, if someone's hypertensive, what happens to heart rate?
Someone's hypertensive?
I said cardiac output is controlled most effectively by heart rate. And so if someone's hypertensive, in the absence of other factors, heart rate tends to drop a little bit, right? So that you don't have so much cardiac output. Now, things like stress and, you know, sympathetic system and hiccups can cause the not only hypertension but a higher heart rate, and that's not good, right? Because that'll lead to contribute to hypertension. But if someone's hypertensive, sometimes the heart rate will go down a little bit to accommodate for the hypertension, so it doesn't add to it. On the other side, if they're hypotensive, heart rate will go up so that you can start to thwart cardiac output and increase cardiac output rather to thwart that hypotension. And it'll go up to 150 beats per minute. Okay. What are some reasons for hypoperfusion? Decrease in volume, so a problem with the fluid in the container, right? So we don't have fluid in the container, that's a problem, right? The size of the container and whether the container has integrity, right? So if there's trauma that has opened the container and it can no longer contain the fluid, that's a problem. If the container opens up because of, bless you, what kinds of shocks? Neurogenic, vasogenic shocks, then that also leads to hypotension, right? And then, of course, the third one is a problem with the the pump itself, right? That lends to not being able to move the blood around in any way, shape, or form. Okay, good. What are the four main classifications of shock?
Cardiogenic, neurogenic.
Hypovolemic, cardiogenic, neurogenic, vasogenic, right? We talked about distributive shock and what was the other one? Obstructive, right? Okay. So how do those play in then to these types of shock?
Distributive shock is kind of like an overarching classification for both neurogenic and vasogenic.
Right?
Obstructive.
So that could lead to a cardiogenic kind of shock, but you're described, it's the way these are described, right, as to leading you to what things are. And so,
Isn't the obstructive shock an extrinsic factor? 'Cause it needs the tamponade in the blood vessel.
that is correct. Yep. Okay? So if you hear those in those different ways, you know how to describe them and what they all mean, right?
So are you saying that obstructive shock is kind of like almost falls under the cardiogenic shock too?
Obstructive can cause cardiogenic.
And what might an obstructive cause cardiogenic shock?
So if you have a tension pericarditis, you've got tension pneumothorax, you've got a pneumothorax, whatever, any of those kinds of things, those are reducing the capability of the heart to work. And so you're describing the reason for the shock. The issue is centered in the heart's inability to work, which would make it cardiogenic. Typical cardiogenic shocks we would consider to be of origin within the heart, intrinsically, not extrinsically. And so could you lump them together? Sure, it's not the best to do, quite honestly. I would call them differently, right? Honestly, from an intrinsic versus an extrinsic reason for it. If you were sort of being broad about it, you could consider it. It's really in context of how you describe it.
So why don't they have 5 classifications of growing obstructive?
There's actually custom anatomy tests, so starting has 3 classifications.
Yeah.
Obstructive, cardiogenic, distributive.
So it's also dependent on what you're reading, right? So that's how, as long as you know those and recognize those, then you understand it and you can describe it to whomever you're talking to about what's going on with the individual. But being able to understand it in that fashion is what's important. Okay, everybody got all that? Do you all understand that? Okay. All right. So, talk to me about the renin-angiotensin system. It's a big picture. It's a big picture view of what's going on, right? Okay, so what's the big picture view? Let's start with hypotension. What happens when we have hypotension in the body?
The glomerular
No.
says they have the afferent.
What is it?
And
cells.
okay, very good. Juxtaglomerular cells, okay, good. And what happens then? All right, so it starts excreting renin, right? And what does renin do?
Converts angiotensin that into angiotensin 1.
Okay, good. And then what happens?
Angiotensin 1 binds with the ACE inhibitor from the lungs to make angiotensin 2.
With the ACE inhibitor?
The angiotensin.
Yeah, thank you.
With what?
Angiotensin converting enzyme.
Yes. Okay, with angiotensin converting enzyme. and that converts angiotensin 1 to angiotensin 2. And what are the effects of angiotensin 2 on the body?
Increased sympathetic response,
Yes, which means,
increased heart rate.
yep, vasoconstriction. Okay, right? What else happens? Angiotensin 2.
Antidiuretic hormone.
Okay, ADH
Or
and aldosterone. Okay, and what else happens?
Retention of certain salts like sodium chloride,
Excretion of potassium,
concentration of potassium, and then that's also going to lead to retention of fluid
retention of fluid, hopefully,
in the kidneys.
if there's fluid to retain, right? And all those things should hopefully increase blood pressure. And if that works, then the kidneys stop excreting renin, and after some short time, that cascade stops in and of itself. Okay? All right, good. In the clotting cascade, which pathway is because of a exposure to collagen or tissue? The intrinsic or the extrinsic? The left arm or the right arm? The left arm, which is the intrinsic pathway, right? And so the extrinsic pathway is a different component of the cascade, but it's not because of a actual exposure to something like collagen tissue-wise. And so both of those pathways lead down to factor 10, right? And then on down to actual clotting. And so we've got kallikrein and bradykinin with factor 12 and 12A that interacts with them, and these things produce bradykinin, right? Prekallikrein and kallikrein. Prekallikrein converts to kallikrein, and then we've got bradykinin that's produced from this, right? And what happens with bradykinin? What does that do? Increase inflammation. It's a picture. It's got all kinds of things. Sympathetic action, angioedema, and bronchoconstriction. Okay, right? And what happens if that's left unchecked? Death. Right. Right. Okay. Good. And so take a look at that whole chart as well, right? Just to get a sense of it, and just an exposure to that again. Okay. He's out. I'm out. I'm done with this.
Doors, that's why I was like, I saw the door crack. I was like,
Yeah. Well, that's enough. I've had it. Talking about kallikrein and prekallikrein, bradykinin, I'm out.
Oh no, she fully understands it. She ate the textbook. She ate the textbook.
Very good. All right. So that's sort of a general look at things. Any questions on that stuff? Again, take a look through your quizzes. Do you have any questions on things? Yes.
So on that one picture where it goes down the coagulation cascade, there was a part on the side that was like talking about if you took out one part, it would lead to like lupus, like it had other.
I'm not going to touch on that. That's for your information to understand it.
Okay.
Not that I'm going to touch you on those components. Like, I just want you to know that there's different components that could be affected by a disease process and or create a disease process that we understand it to be a disease process if there's a defect in any components of those cascade systems.
But knowing the end result, like the map and all that, that's pretty important.
Yeah, so you should understand the membrane attack complex is the thing that's going to help kill other pathogens, but they also affect a particular really important cell, our red blood cells, right? Okay, and so we have a process for that too. Okay. Questions, thoughts? All right, look through those things. Okay, if you have questions, reach out. I'll absolutely do my best to stay on email with Duchess to make sure that I've looked at things that you have. Okay, let's take a quick break, and then we'll come back and we'll do the autopsy slides, okay?
Are we